Hello and welcome to Insight Ophthalmology. This is Dr. Amrit, welcoming you to another lecture on the lacrimal apparatus series. Today we are talking about the dacryocystitis. So what is dacryocystitis? As the name suggests, it is basically inflammation of the lacrimal sac. Dacryocystitis can be actually of two types, acute dacryocystitis and chronic dacryocystitis. In acute dacryocystitis, there is sudden infection or inflammation of the lacrimal sac, which is basically caused by some bacterial infection. And therefore, we have abrupt onset of symptoms in acute dacryocystitis. Whereas in chronic dacryocystitis, there is a chronic nasolacrimal duct obstruction which occurs gradually over a period of time and also persists for a longer duration of time compared to the acute dacryocystitis. We can also classify dacryocystitis as congenital dacryocystitis and the acquired dacryocystitis. The congenital variety is seen in newborn infants, and it is basically because of the membranous obstruction in the distal part of the nasolacrimal duct because of the partial canalization or failure of the canalization of the nasolacrimal duct during the embryological period. The acquired dacryocystitis could be because of the trauma of the nose, certain sort of nasal surgeries, endonasal surgeries, various sort of medications which can cause strictures in the nasolacrimal duct, leading to closure of the nasolacrimal duct and subsequent obstruction and infection, various neoplasms, masses, and also stones which can get lodged in this nasolacrimal duct. Now, the stones in the nasolacrimal duct or in the lacrimal sac is called dacryolyths. Now, the point to be noted are the drugs which are causing acquired dacryocystitis. Now, as you can notice, various types of anti-glaucoma medications and the antiviral medications when used topically can cause the acquired dacryocystitis. These are timolol, pilocarpine, dorzolamide, idoxuridine and trifluridine are your antiviral drugs. And apart from that, we also have certain oral medications, basically the chemotherapeutic agents like the fluorouracil and docetaxel. Now, if you observe, congenital dacryocystitis is basically chronic in nature, whereas the various sort of acquired dacryocystitis can either be acute variety or they can also present chronically. Now, because the chronic dacryocystitis is more common compared to the acute dacryocystitis, we shall be studying about the chronic dacryocystitis first. So, who is at risk to develop chronic dacryocystitis? Number one, young adults because they can undergo various sort of trauma, adults who undergo various surgeries, okay, and who have stone in their lacrimal apparatus, which is called dacryolythiasis. Then again, when the age is above 60 to 65 years, they usually demonstrate increased narrowing of the nasolacrimal duct with age. Again, females, because females, as I told you in my previous video, they have much more narrow lumen of the bony canal. They have much thinner nasolacrimal duct and more prone to developing obstruction of the nasolacrimal duct and subsequently development of the dacryocystitis. So here the concept that you should understand is that whenever there is obstruction, there will be stasis of the tear, and this old tears which are present in the lacrimal sac are basically prone to develop bacterial infection and therefore leading to development of the dacryocystitis. Again, when you see race as a risk factor, the Caucasians are at a greater risk compared to the colored races because the Caucasians actually have much thinner, longer and sinuous nasolacrimal duct compared to the colored races where the duct is much more shorter, wider and less sinuous. Again, low socioeconomic status and the poor personal hygiene is also considered to be a risk factor. Here, an important abbreviation that we all must know is PANDO, which stands for Primary Acquired Nasolacrimal Duct Obstruction. As I told you, as the age increases above 60 to 65 years of age, what happens is that there is gradual narrowing of the nasolacrimal duct with age, and this condition is called primary acquired nasolacrimal duct obstruction. So, what causes this chronic dacryocystitis? So, what is the pathophysiology behind it? Now, basically, multiple factors are involved. However, you must understand that there is actually a vicious cycle of stasis of the tear and mild infection of longer duration within the lacrimal sac. So remember, there is stasis of the tears in the lacrimal sac, and then ultimately, because of that stasis, we develop infection in the lacrimal sac, leading to chronic dacryocystitis. So here, what are the factors which lead to stasis of the tears in the sac? Obviously, there are some anatomical factors that you might have understood by now, like the narrow canal, sinus canal, partial canalization of the membranous nasolacrimal duct, which is a cause in congenital dacryocystitis, excessive folds in the nasolacrimal duct. So, all these conditions, all these anatomical factors actually predispose the nasolacrimal duct to get obstructed, and therefore development of stasis of tears in the lacrimal sac. Apart from that, when you have excessive lacrimation, now this excessive lacrimation could be either primary or secondary or reflex lacrimation. However, when you have excessive tearing, what happens? The excessive amount of tears actually reach your lacrimal sac, and this also causes stagnation of the tears in the sac. Apart from that, when you have some low degree or mild grade of inflammation going on in the lacrimal sac, this could be because of some recurrent conjunctivitis, okay, and this will cause blockage of the nasolacrimal duct because of the epithelial debris and the mucus plug, which are generated because of this recurrent episodes of conjunctivitis. And later on, these epithelial debris and mucus plugs are going to go and block your nasolacrimal duct. Apart from that, nasal disorders are also a risk factor that can cause stasis. How? We can have extremely deviated nasal septum, which will lead to development of a narrow ostium on one side, and we have a wider nasal cavity on the other side. Similarly, if you have atrophic rhinitis, then also your nasolacrimal duct mucosa might get affected and might actually undergo atrophy and finally stenosis. Then you have inferior turbinate hypertrophy, which might actually block your nasolacrimal duct. So, if you would remember, the nasolacrimal duct basically opens ultimately into the inferior meatus, which is present below the inferior turbinate. So, if your inferior turbinate is hypertrophied, what will happen? It is going to actually press upon the opening of the nasolacrimal duct, leading to blockage of the nasolacrimal duct. Apart from that, sometimes you can have the saddle nose deformity. Such patients also have lesser space within the nasal cavity, and therefore they are more prone to developing obstruction and stasis of the tears in the sac. So, this is basically a summarizing slide which summarizes the factors which can cause stasis of tears in the sac. So, we have anatomical factors, we have excessive lacrimation as a factor, nasal disorders, and mild grade inflammation going on in the sac because of recurrent conjunctivitis. So, the first factor we studied now is the stasis of tears. Next, what will happen is there will be some infection. And as I told you, it's basically because of bacterial infections. So, what are the organisms which will actually cause this? So, we have Staphylococcus, Pneumococcus, Streptococcus, Pseudomonas, and very, very rarely we can also have these infections like TB, syphilis, leprosy, and even rhinosporidiosis coming and infecting your sac. Before we proceed, it's trivia time. So, which specific corneal ulcer is common with chronic dacryocystitis? So, if you know the answer, quickly comment the answer in the comment section. And in the previous two videos, we had asked two questions, and the correct answer was actually given the fastest by Girish Methi for both the videos. And therefore, the shout out and shine out goes to Girish Methi. Well done. Now we are going to study about the clinical stages of chronic dacryocystitis. The clinical stages are basically four. We have stage of chronic catarrhal dacryocystitis, then we have stage of lacrimal mucocele, stage of chronic suppurative dacryocystitis, and then we finally have the stage of chronic fibrotic sac. So we are going to talk about all of these one by one. So first let us talk about the stage of chronic catarrhal dacryocystitis. Here what happens is that we have just mild inflammation of the lacrimal sac associated with blockage of the nasolacrimal duct. So obviously you know that in order to get dacryocystitis, we need to have some sort of blockage in the nasolacrimal duct which causes stasis of the tears in the lacrimal sac. So the same will happen in this case as well. However, the inflammation that occurs in the lacrimal sac here will be very, very mild. Apart from that, the only symptom that the patient is going to complain about is the watering. Also, there might be some amount of redness at the inner canthus. Now, at this point, I would like to introduce one more term, and that term is ROPLAS. The ROPLAS, or ROPLAS, it stands for regurgitation on pressure over the lacrimal sac. So, what happens is if you were to put pressure over the lacrimal sac, which is already harboring a lot of tear fluid stagnated inside it, what will happen, that tear fluid is actually going to come out through the canaliculi. That means it is going to regurgitate to the canaliculi because we have obstruction at the distal end of the nasolacrimal duct, and this therefore is called a positive ROPLAS, that is regurgitation on pressure over the lacrimal sac area. Obviously we can't put directly pressure on the lacrimal sac, and therefore we are going to put pressure basically on this area of the lacrimal sac which is situated below the inner canthus. However, this test is not as sensitive as your syringing and therefore should not replace syringing as a pre-operative test before cataract surgery. Now, as we were talking about the stage of chronic catarrhal dacryocystitis, so here I told you that there's just mild inflammation. So even when you do syringing, what will happen is you will get a clear fluid or few fibrinous mucoid flakes on regurgitation, right? So similarly, if you carry out a ROPLAS test also, you might get just clear fluid or few flakes in that clear fluid. Similarly, when you carry out dacrocystography, which is a fluoroscopic or contrast test to image the lacrimal apparatus, you are going to see that there is some sort of blockage in the nasolacrimal duct. However, the lacrimal sac size will be normal and the mucosa will be healthy because this is just the first stage of chronic dacryocystitis. Now let us move to the second stage, which is the stage of lacrimal mucocele. So what happens here is that I told you in dacryocystitis, we have an obstruction at the distal part of the NLD, and because of which we have stasis of tears. Now chronic stasis will actually lead to distension of the lacrimal sac, and this distended lacrimal sac will present as a swelling at the inner canthus, and this swelling is called the mucocele. Okay, now at this point the patient is going to have constant epiphora or watering. Now what if you do syringing or you press the sac, that means carry out a ROPLAS test. Now at this stage the fluid will be slightly more milkier or gelatinous compared to what you saw in the catarrhal stage. Okay, and when you carry out dacrocystography, obviously you are going to see a distended lacrimal sac. So that is one important point to remember. As you can see over here in this picture, the first picture you can see there is some sort of swelling which is present in the lacrimal sac area, and when you actually press over this lacrimal sac area, you can see there is regurgitation of the mucopurulent discharge, telling you that we are dealing with a mucocele that is actually now progressing towards the next stage, which is the stage of the pyocele. Now, before we jump to the pyocele, one important point to remember is what is an encysted mucocele. Now, sometimes what happens is that because of the chronic stasis and because of the chronic inflammation, even the canaliculi will get blocked along with the blockage at the nasolacrimal duct. Now, in this stage, if you were to apply pressure on the lacrimal sac, what will happen? There will be no regurgitation because there is no place for the regurgitate to come out, right? So as the opening of both the canaliculi to the sac also gets blocked, there will be a development of that large fluctuant swelling seen at the inner canthus. And when you carry out a regurgitation test or the Ropla's test, that test is also going to be negative here. So it is as if the entire tear or the entire regurgitate is actually encysted within that cavity, and therefore this is called an encysted mucocele. Now let us talk about the third stage, that is the stage of chronic suppurative dacryocystitis. Now what happens with time, that stasis or that stagnated tears or stagnated fluid or material within the lacrimal sac will actually get infected because of the pyogenic organism, and therefore your mucoid discharge will now become purulent, and this mucocele is going to get converted into pyocele now. Okay, now at this point patient will have epiphora, and also they will complain of recurrent conjunctivitis, swelling at the inner canthus with mild erythema of the skin. Now because infection has occurred, now what will happen is that you will also see surrounding changes. That means the eye will get infected, the conjunctiva will get infected, leading to recurrent episodes of conjunctivitis. Also the skin over the sac, the lacrimal sac area, will look inflamed, because we now know that the infection is spreading and the inflammation is increasing. Now, if you carry out a regurgitation test now, frank purulent discharge will flow through your punctum. So basically, you differentiate mucocele from pyocele by the absence of signs of inflammation in case of a mucocele. However, in pyocele, you will see that there is purulent discharge inside, and the surrounding structures like the skin and also the conjunctiva is going to show signs of inflammation. Coming to the last stage, that is the stage of chronic fibrotic sac. Now, ultimately, what is going to happen because of this constant inflammation which is present and repeated low grade infection by organisms within the lacrimal sac, ultimately there will be fibrosis, because the end result of inflammation, as I have already mentioned in a lot of my videos, is fibrosis. Ultimately, the mucosa is going to get fibrosed, and therefore you will have this small fibrotic sac with thickening of the mucosa. At this point, patient will again have epiphora. However, this fibrotic sac cannot produce mucoid or purulent discharge, and therefore the only discharge that you're going to see is a watery discharge. At this stage, if you carry out syringing, you might see watery or a very slight mucoid discharge, and on dacrocystography, it will reveal that the patient has a small sac with irregular folds in the mucosa or a thickened mucosa. So that was your stage of chronic fibrotic sac, and with this we finished the various stages of chronic dacryocystitis. Now, we should also know that what are the various complications that the chronic dacryocystitis may actually lead to. So, first is because the infection is chronically present in the lacrimal sac, the patient can develop multiple episodes of conjunctivitis and often can develop chronic intractable conjunctivitis. That means such a sort of conjunctivitis will not respond to your therapy because the infection is not present in the conjunctiva, it is present in the lacrimal sac area. So even if you are going to keep on giving the patient topical antibiotics, the conjunctivitis will not resolve. Now, apart from that, even the cornea can get infected. If you have some simple corneal aberrations because of trauma or any other reason, those simple corneal aberrations can get infected, and the patient can actually develop this hypopyon corneal ulcer. Apart from that, because we know in chronic dacryocystitis what happens is that patient will have constant epiphora or watering, and because of that watering, he might also develop itching of the lower lid, and because of that constant rubbing and itching, there's going to be weakness in the muscles of the lower lid, leading to the ectropion of the lower lid. That means outward drooping of the lower lid, maceration and eczema of the lower lid skin because of that prolonged rubbing and watering. Now, there's one very important complication that you must remember, and that complication is that of the endophthalmitis. It is very, very important that you do not proceed with an intraocular surgery if there is any sign of lacrimal drainage system infection. Either you have done a Roplast test and there is a regurgitation of clear fluid, mucoid fluid, or purulent fluid, it does not matter, from the canalicula's, you have to postpone your surgery, because if you proceed with the surgery, the infection is going to spread not just to conjunctiva but within the ocular fluids, that means your aqueous humor and your vitreous humor, leading to development of endophthalmitis. And such endophthalmitis does not just stop at endophthalmitis, it can also involve the various coats of the eye and lead to development of the panophthalmitis. So this is a very important clinical nugget that you must remember, that postpone your intraocular surgeries, whether it is cataract surgery or glaucoma surgery, till you deal with the dacryocystitis. So now the question is that if the patient has this chronic dacryocystitis and we don't treat it, does it heal on its own? So it's very rare for an untreated chronic dacryocystitis to heal spontaneously. The condition, as I told you, it's going to keep on progressing from the catarrhal stage to the mucocele, then pyocele, encysted pyocele or mucocele, and ultimately leading to development of an atonic sac or a fibrotic sac. Because the sac has become atonic, the lacrimal pump will fail, as I told you in my previous video on understanding the lacrimal pump and the Jones diet test. So what will happen? Patient will have this epiphora, okay, and therefore, and what will happen is, subsequently, again and again, the lacrimal sac might get infected by the organisms and leading to acute episodes of inflammation. So you will get this acute on chronic dacryocystitis, right? So, how do you basically treat a chronic dacryocystitis case? So, first of all, whenever there is an acute inflammation in cases of chronic dacryocystitis, you deal with that acute inflammation. That means when you have a lacrimal abscess developing, when you have pyocele developing, okay, whenever the signs of inflammation increase, you basically manage those cases first and then you go ahead with surgeries. Now, as we talk about the acute dacryocystitis, I will actually mention in detail how do we manage the cases of acute dacryocystitis. However, the mainstay of treatment for chronic dacryocystitis is basically surgery. You can either do a dacrocystorhinostomy, which is called DCR, or you can do an older procedure which is called dacrocystectomy. However, the procedure which is the best is a DCR. So in DCR, as I told you before, we create an anastomosis between the lacrimal sac and the nasal mucosa by chipping out some of the lacrimal bone. So in order to create a bypass of the obstruction which is present in the nasolacrimal duct. So as we create this opening here, the tears will directly drain into the nasal cavity without having to pass through this nasolacrimal duct. So that is called a creation of an opening or a dacrocystorhinostomy. Now, if you want a detailed video on DCR, comment in the comment section so that I know what do I need to focus upon in future. So, next surgery is dacrocystectomy. So, basically, what we are doing in dacrocystectomy is that the entire lacrimal sac, along with the nasolacrimal duct, is basically removed. However, there are specific indications for DCT. Now let us talk about the acute dacryocystitis. So acute dacryocystitis is not as common as the chronic dacryocystitis, and therefore we discussed about the chronic dacryocystitis first. So what is this acute dacryocystitis? Acute suppurative inflammation of the lacrimal sac, which is basically of bacterial origin, characterized by a presence of a painful swelling in the region of the lacrimal sac, is called acute suppurative dacryocystitis or acute dacryocystitis. So what is the etiology? Basically, you can have an ongoing chronic infection lingering in the sac, and that infection can suddenly increase, leading to an acute exacerbation on chronic dacryocystitis or an acute dacryocystitis in a patient who already has a chronic dacryocystitis. Apart from that, you can have acute peridacryocystitis. That means the dacryocystitis or the infection will actually come from the neighboring structures. So you already have some paranasal sinuses which are infected, or it is going to come from the surrounding structures like a dental abscess or caries of the teeth of the upper jaw as well. So infection from the neighboring structures can also spread to your lacrimal sac, leading to acute inflammation or acute infection of the lacrimal sac, leading to acute dacryocystitis. So what are the organisms which are involved in acute dacryocystitis? So here we basically have the staphylococcus, streptococcus, and the pneumococcus. Again, let us discuss the clinical stages of acute dacryocystitis. The clinical stages of acute dacryocystitis are the stage of cellulitis, stage of lacrimal abscess formation, and stage of fistula formation. So here we only have three stages. First, let us discuss about the stage of cellulitis. So here what happens is that as there is infection in the lacrimal sac, there will be a painful swelling that develops in the region of the lacrimal sac area. As you can see here, patient is going to complain of epiphora, and along with that they will also have constitutional symptoms like fever and malaise. And when you actually examine the patient, there will be a red hot firm tender swelling, tender to touch, okay, in the lacrimal sac area. Now sometimes this inflammation will be so much that it is actually going to spread. The redness and edema can actually spread to the lids and also to the cheeks. At this point, it becomes very important to differentiate between these two conditions, that is the erysipelas and the dacryocystitis. Now in erysipelas, it's basically the infection of the subcutaneous tissue. So if you notice here, the redness or the cellulitis will be greater in the cheek area, whereas in case of a dacryocystitis, it is more limited to the lacrimal sac area. That means the redness will be more here, and then as you progress or as you observe your cheeks, the cheeks will be less red compared to the lacrimal sac areas. However, in erysipelas, the redness will be more in the cheek area compared to the lacrimal sac area. So how do you basically treat the stage of cellulitis? So what we are going to do in this video is that as we progress along the stages of the acute dacryocystitis, we should also be discussing the treatment of the various stages, right? So treatment at this stage, at the stage of cellulitis, is very simple. You can give systemic antibiotics, you can give penicillins, cephalosporin, and if the patient has any sort of allergies to penicillins or cephalosporin, you can actually use erythromycin or clindamycin, okay, which are the macrolides. Apart from that, topical broad spectrum antibiotics can also be given to prevent any conjunctivitis from developing, or to treat any conjunctivitis which has developed as a result of dacryocystitis. And because there's inflammation, there will be pain, so you have to give the patient systemic anti-inflammatory analgesic drugs. Apart from that, something which works very well is hot fomentation or a hot compress, and it basically helps in reducing inflammation and helps the patient with pain and the swelling. The next stage is the stage of lacrimal abscess formation. Now, what will happen? The continued inflammation and continuous infection is basically going to now cause occlusion of the canaliculi, something very similar to what happened in the mucocele. Okay, but of course, this happens because of the increased infection and pyogenic material. So, sac is now going to be filled up with pus, it is going to become distended, and now you will have a large fluctuant swelling with signs of inflammation sitting at the inner canthus, and this is called lacrimal abscess. Okay, so at this point I would just like to briefly tell you what is meant by a fluctuant or a non-fluctuant swelling. A fluctuant swelling is basically when you place your two digits on the either side of the apex of the swelling, and you put pressure at the center of the swelling or at the apex of the swelling. Okay, you will find that the two digits will be pushed away from each other, and this is called a fluctuant positive test. Okay, so if a swelling is fluctuant, it basically tells you that there's presence of fluid within the swelling. In this case, it is basically the pus which is present within the lacrimal abscess. So as you can see over here, this is this painful swelling that has developed for this patient with signs of inflammation, and it actually tells you that you're dealing with a lacrimal abscess. Okay, in cases of cellulitis, in cases of the first stage, that is the stage of cellulitis, you will not see this well formed swelling at the inner canthus. All you're going to see is erythema and redness. But here you can see this organized swelling at the inner canthus, and oftentimes it will also develop basically a pus point. Okay, and this pus point is, for most of the times, it is going to actually be present here somewhere because of the gravity, and also because I told you that the lacrimal sac is basically covered on in its upper part with the medial palpebral ligament, and therefore the lower part is slightly weaker, and therefore all the pus is also going to come to the lower part because of gravity, and then the patient will develop a pus point in the lower part of the lacrimal sac area, right? So, what is the treatment of lacrimal abscess? As we know that abscess anywhere needs to be drained, so here also the treatment would be incision and drainage. Of course, you can advise the patient to use hot compress, and many a times this hot compression actually will lead to spontaneous drainage of the lacrimal abscess. However, you can actually carry out an incision and drainage. The problem with incision and drainage is that it can sometimes lead to development of an external fistula. Now, lacrimal abscess, whenever drained, should always be sent for culture and sensitivity, and then you can actually start the patient on these sensitive antibiotics. Apart from that, once you have carried out incision drainage procedure, you should also fill up that tract that you have created with a broad spectrum antibiotic ointment. You can also use some povidone iron soaked gauzes. And after you have done incision and drainage or an IND procedure, make sure that you instruct your patient to continue hot compresses throughout the day, so that what happens is that as the patient does hot compresses or hot fermentation, the remaining pus which might be present in the lacrimal abscess might also drain out through the tract that you have created by the IND procedure. Now, the question is that you have done an IND for a patient with lacrimal abscess, but do they need any dacryocystitis surgery later on? So, what happens is that infection usually causes fibrosis and scarring, and it is very rare for a nasolacrimal system to open up spontaneously, and therefore, surgery will definitely be required. Even once the acute dacryocystitis settle up, you have to counsel the patient and that most of the patients will finally require a dacrocystorhinostomy procedure or a DCR procedure. Now coming to the last stage, that is the stage of fistula formation. So sometimes when the abscess is unattended, it discharges spontaneously, and sometimes even after an IAD, a fistulous tract or an opening actually develops in the skin, right? So if there's an opening that develops from the sac externally into the skin below the medial palpebral ligament, which is present over here, okay, and the opening you can see here, which is discharging the mucus from the lacrimal sac. Now this opening is called an external fistula. Very rarely the abscess actually is going to open up inside the nose, and that is called an internal fistula. So, how do you treat a fistula? Obviously, everywhere you have to control the acute infection first, okay? And then you can do either your DCT with fistulectomy, or you can carry out a DCR procedure. So, with DCR, what happens is that since you're creating an alternative opening of the lacrimal sac into your nasal cavity, then none of the fluid is actually passing through your fistulous tract, and the fistula tract might actually close on its own. Now, so what are some of the complications of acute dacryocystitis? So you can get an acute conjunctivitis, you can get ulcers in the cornea or infection in the cornea, basically an hypopyon corneal ulcer, or this infection can actually spread into the lid leading to the lid abscess, or it can spread into the subcutaneous tissue around the eyelids leading to the preseptal cellulitis. It can actually spread within the orbit also, and this actually happens in diabetic patients or immunocompromised patients, leading to the orbital cellulitis, and it can also spread to the facial cellulitis. Now here you can see this picture collage. In the first picture, you can see this is the stage of acute dacryocystitis. You can see a lot of cellulitis in this patient, and the patient is actually also having some sort of preseptal cellulitis. You can see all this inflammation present. And in the second picture you can see there is abscess, and the abscess has actually formed a pus point. Okay, and in the third stage you can see that if you actually instill fluorescent drops within the patient's conjunctiva, you can see these drops are actually coming out externally through the skin. That means that there is a fistula which is present. And in the fourth stage, the same patient when I underwent dacryocystitis, you can see this fistula is opening. This is actually a healed lacrimal fistula. Now, at this point, I would like to remind you all that never carry out syringing in case of acute dacryocystitis. The signs of acute dacryocystitis are straight away. You don't need syringing for its diagnosis. Moreover, it is very, very painful for the patient if you carry out such a procedure. Even if you touch the patient in order to do a ropelas, it is very, very painful. So, it's always advisable that you refrain from doing such procedures in a patient with acute dacryocystitis. So that's all for today. I hope it was useful. If this video was of any value to you, kindly hit that subscribe button. It makes a lot of difference for the channel. Thank you and have a nice day.